Hello! In this video, we will talk about adrenal incidentaloma and how to investigate it. An adrenal incidentaloma is an unforeseen mass lesion in the adrenal gland greater than 1 centimeter discovered during an investigation for an unrelated condition. This tutorial will define what investigations should be done in these cases and how to detect high-risk adrenal lesions that require a specialist assessment. Adrenal incidentalomas are usually discovered during thoracic and abdominal scanning as a part of the investigation for an acute or chronic condition. They are detected in 2% of the general population and 7% of people older than 70. Adrenal incidentalomas rarely appear in children and young adults. They are often malignant and should always prompt a specialist referral with proper investigation. In adults, though, most adrenal incidentalomas are benign and non-functional. Among the malignant lesions, 50% are functional and secrete cortisol, aldosterone, catecholamines, and very rarely sex hormones. All adrenal incidentalomas should be investigated. Imaging assessment is usually paired with biochemical assays for the detection of the functional activity of a mass. Small non-functional lesions with a benign appearance on CT scan usually do not progress and do not require additional investigation. Larger lesions have a higher propensity to be functional and malignant, especially in the presence of cortisol-related conditions such as hypertension, glucose metabolism disorders, weight gain, dyslipidemia, and osteoporosis. In asymptomatic patients, the current guidelines recommend repeated CT scans with hormonal assays annually for 3-5 consecutive years. Once the tumor growth is detected or hormonal excess is confirmed, a patient should be referred to a specialist for further management. Patients with larger functional adenomas or indeterminate lesions with apparent or occult hormonal activity should always be referred to a specialist. A non-contrast CT scan is the most commonly used imaging of the adrenals. It provides essential details about the lesion structure and allows the detection of purely benign or highly suspicious lesions. Benign lesions are usually smaller than 4 cm and rich in fat content. They have a homogeneous structure and regular borders. Malignant lesions are significantly larger and denser. They have a rich vascular supply and irregular margins. Such lesions should be managed urgently. Adrenal masses with indeterminate imaging features require additional assessments similar to suspicious lesions, but not urgent. A contrasting CT scan with a calculated contrast washout ratio provides additional data about vascular supply and drainage of a lesion. Benign lesions show more than 60% clearance of the contrast agent in 15 minutes. Malignant lesions tend to take up a contrast medium with a calculated washout of less than 40% of the injected dose. Adrenal tumors secreting hormones are called functional. They may secrete one or several substances at once, therefore multiple screening tests are required. The current guidelines recommend a low-dose dexamethasone suppression test or a late-night salivary cortisol assay at the first screening modality to rule out autonomous cortisol secretion. These tests offer high accuracy and are convenient to conduct. To avoid possible false results, they should be repeated at least twice with an interval of several months. Mineralocorticoid secretion is assessed in patients with hypertension and hypokalemia. Screening tests include plasma aldosterone concentration and calculated aldosterone-renin ratio. As in any adrenal lesion could potentially be pheochromocytoma, 24-hour urine metanephrines and vanillyl mandelic acid assays should be done for screening. Sex hormones assay are crucial in investigating cases with clinical signs of androgen excess or feminization. An interpretation of the hormone test results can be challenging. The clinical guideline of the European Society of Endocrinologists advises on the following. Apparent cortisol excess is confirmed when a morning cortisol level is more than 5 micrograms per deciliter after 1 mg overnight dexamethasone dose, or more than 145 micrograms per deciliter in a late-night salivary cortisol assay. Apparent cortisol excess is securely excluded with a morning cortisol level of less than 1.8 microgram per deciliter in a low-dose dexamethasone suppression test. These results should be confirmed with an additional assay, usually assigned by an endocrinologist. The cases with cortisol levels in between should be further investigated by endocrinologists. Hyperaldosteronism is proved if plasma aldosterone concentration is higher than 20 nanogram per milliliter and the aldosterone-urine ratio is greater than 20. The cutoff for detecting catecholamine excess is 1.8 milligram of metanephrines in 24-hour urine collection. The vanillyl mandelic acid concentrations should be greater than 11 milligram in the same urine sample. Levels of androgen or estrogen above the normal range define sex hormone excess. Most adrenal lesions do not require biopsy. Moreover, many studies failed to demonstrate a significant benefit of biopsy on prognosis, and neither can it influence a management plan in most cases. Nevertheless, in some cases, a biopsy is recommended. It includes an investigation of a non-functioning lesion suspicious of malignancy, usually on the background of secondary malignancy. In this case, an adrenal biopsy can potentially affect a treatment plan and improve a patient's prognosis. Bilateral adrenal masses are always pathological. Therefore, once detected, a patient should always be referred to a specialist for further assessment. To sum up, remember, adrenal incidentalomas are common. Always investigate adrenal masses as they may be functional and malignant. Small lesions with low density on CT scans, Hounsfield units less than 10, are almost always benign. Non-functional and benign lesions may be followed with repeated CT scans and hormonal assays. And finally, refer for a specialist assessment of any suspicious or functionally active lesion. Thank you for watching.